Before I start the presentation, we're going to be gauging your confidence in the results as we go by using a QR coding polling system that Patrick set up. So please keep your phone out so that you can scan the QR code when you see it. So fluoroquinolones are broad-spectrum antibiotics. They're indicated for a broad range of infections such as pneumonia, bone and joint infections, and also urinary tract infections. The use of these antibiotics is rising internationally, despite the recommendation that the antibiotics should be used judiciously. This is mainly driven by resistance to other antibiotics that are used to treat the same infections. Thankfully, though, fluoroquinolones are generally well tolerated, the most common side effects just being some mild vomiting or diarrhea or maybe some abdominal pain. However, there are reports of serious adverse events such as tendon ruptures. So on the topic of the tendon ruptures, there have been several warnings about the risks of serious adverse events with the use of these drugs. In 2008, the FDA put out a black box warning on these products, warning about the increased risks of tendinitis and tendon rupture. Years later, they enhanced these warnings and included warnings of joint pain, altered mental status, and also later increased risks of aortic aneurysms or dissections. These warnings were primarily based on the findings from epidemiologic studies, and in the case of aortic aneurysm and dissection, how the antibiotics actually cause these adverse events isn't still well understood, although we think it could be a link to the fact that there are similar types of collagen in both the aorta and the tendons. In 2018, the EMA also reviewed rare serious adverse events and put restrictions on the prescribing of these drugs, and the TGA here in Australia also investigated the risk as well and updated the product information here in Australia. More recently, though, in the lead up to the SOS challenge, there has been emerging evidence that perhaps there is no increased risk of aortic aneurysm or dissection with these medicines. So firstly, though, what is an aortic aneurysm or a dissection? So the aorta is the main artery that carries the blood from your heart to the rest of the body. An aortic aneurysm is when the walls of the aorta become really thin and it starts to bulge out. So you can see that on the left-hand side there. If it becomes really thin, it can actually rupture and it can actually be fatal for the patient as well. On the other hand, dissection is when there's a tear in the walls of the aorta. Blood can then get in between those layers, and if the tear goes through the wall, it could lead to some internal bleeding, which could again be fatal for the patient. So we're talking about really serious outcomes for our patients here. I mentioned before that these warnings have primarily been made on the basis of epidemiologic studies. One of the most recent meta-analyses of 5 observational studies described the quality of the evidence of the association as moderate. So the meta-analysis included 2.8 million patients and compared use of fluoroquinolones to non-users of antibiotics or users of other antibiotics that are used to treat the same infection. As a primary outcome, they looked at the first occurrence of an aortic disease, so maybe an aneurysm or a dissection. For aortic aneurysm or dissection, the overall odds ratio you can see there on the screen was 2.23, with a range of estimates between 1.66 to 2.78. However, the authors of the meta-analysis did notice some inconsistencies in the study designs. So importantly, there were differences in the patient age ranges that were included, the follow-up duration, and also they highlighted the potential for unmeasured confounding, particularly confounding by indication and surveillance bias. So this might be a little bit small on the screen, but if we look at some of the previous studies that looked at this association, we can see a range of study designs and also note that most studies are from a single country. When we looked at the indication of the fluoroquinolone, it was often not specified, or the study included multiple indications of varying severity. When we looked at which active comparators we used, we also noticed that they often were unspecified, or there was a range of different active comparators used, and often there was limited justification of why they chose that active comparator. When we looked at the outcomes the studies included, we noticed that most did look at aortic aneurysm or dissection. However, the outcome definitions varied. Most required ICD coding of the outcome, and most required hospitalization as well. And some also, you can see, required diagnostic imaging. In terms of positive predictive value for the outcome, it was high where reported, but it was not consistently reported. And also, the risk window varied across the study from 30 through to 90 days. To balance the covariance between treatments and comparators, often propensity score matching was conducted. However, there was no assessment of clinical equipoise, and we'll talk a bit more about clinical equipoise later on. Some studies did address systematic error by inclusion of positive or negative controls. However, it wasn't always conducted, and often only a small number of controls were used. So as I said, as we move throughout the presentation, we're going to be interactively gauging your confidence in the results that we're sharing. To do this, you can scan the QR code that's been held by our friendly koala here. Thanks, Sarah, for that. Or you can go to the website there as well if you don't have a QR code reader on your phone. So the first question there on the board, the first was, given what I have shown you so far, how confident are you that the current evidence is reliable and can be trusted? So I guess also thinking about the evidence that we've shown you, how confident are you that the fluoroquinolones cause aortic aneurysm or dissection? So this question will come up again as well. So thinking about confidence and building trust, how can we actually build trust in real-world evidence? We could do this by using the open science system that Patrick has mentioned previously to help us build that trust and confidence in our results that we share. So in the context of the SOS challenge, as mentioned by Hua, the Sisyphus is a mythological figure who represents the repetitive and laborious task of pushing that boulder up a hill. So I've rearranged Patrick's workflow that he shared earlier on, and we can continue only pushing this boulder up the hill only if we have the right information and our study passes the diagnostic checks that we have along the way. So if we don't pass the diagnostic checks and the data or the evidence isn't up to scratch, then we'll stop pushing the boulder up the hill, we'll take a break and perhaps recognise that the evidence isn't reliable and it shouldn't be used in our overall evaluation of the effect. So given the ongoing regulatory monitoring of the risk associated with these drugs, inconsistencies of prior methodologies and the study results, we thought that the risk of aortic aneurysms with dissections would make a great topic for the SOS challenge. And as it happened, some of our colleagues in Korea also pitched the same idea. So we joined forces to make the ultimate project together. And over the period of the 9 weeks or 7, I think that Patrick mentioned before, with the help of the Odyssey team, we planned and executed this study. And today, on behalf of the team, I'm going to share the results and also how we designed the study as well. So in true Odyssey fashion, we designed the study to characterize, estimate, and predict the risk of aortic aneurysm or dissections with fluoroquinolones. For characterization, we wanted to know what is the rate of aortic aneurysms or dissections after starting these drugs. For estimation, we wanted to know if exposure to the fluoroquinolone increased the risk of experiencing an aortic aneurysm or dissection compared to other antibiotics. And for prediction, we wanted to know for a particular patient starting on these drugs, what's the probability that they go on to have an aortic aneurysm or a dissection? And so in the presentation, you can see I've grayed out the bottom one there. We're going to mainly be focusing on the population level estimate results of the study. So why is an Odyssey study important to help us answer the question in the first place? Using the Odyssey platform, we can engage with multiple data partners. And this is important because with a large number of data partners, we'll have greater power to detect rare outcomes. And that's really important in this case because our outcome is incredibly rare. Also, engaging with multiple data partners, we can improve the understanding of the risk of the outcomes across diverse populations and settings, rather than a single population from one country, as we saw was done in the previous studies. And so through the Odyssey network, we can also implement and standardize a standardized systematic approach across the network to address our study question and hopefully build that trust in real-world evidence. So when setting up the study, we first needed to develop our protocol. The first thing we considered was the cohorts we needed to generate to answer the research question. So for our treatment group, we included people 35 years or older who were starting on a systemic fluoroquinolone. And for our outcome group, we had people who were hospitalized for aortic aneurysms or dissections. And we had a study period there from January 2010 to December 2019. And we chose the end of December there to minimize the impact of COVID-19 on the interpretability of the results. So if we look at the treatment and comparative cohorts a little bit closer, we defined our cohorts as those patients who were initiated on treatment for a urinary tract infection. And the reason we chose this indication was to minimize the misclassification of the condition and its severity, which may have been an issue if we had have selected a different indication. Patients must have had the UTI within the 7 days leading up to starting the antibiotic, and they must not have been hospitalised within the 7 days prior, so they had to be taking the antibiotic in the outpatient setting. For our treatment cohort, we looked at people taking all fluoroquinolones, and we had 2 active comparators. So we had trimethoprim with or without sulfamethoxazole, and we also had a second one, keflasporins there. And we've chosen these on the guidelines and usual clinical care of a UTI. In terms of the outcomes of interest, we had 3. We had 1 aortic aneurysm with or without rupture, 2 aortic dissection, and then 3 we had a composite outcome of aortic aneurysm or dissection. To enter the outcome cohort, a patient could experience a condition occurrence, procedure occurrence, or an observation of the outcome, but they couldn't have had one of these outcomes within the past year, and the outcome must have been diagnosed in a hospital or emergency room visit. We also included approximately 50 negative controls as recommended by a common evidence model. Negative controls are, the outcomes which were considered not to be associated with either the fluoroquinolones or the comparator antibiotics that we use. So we could use these outcomes to test for the systematic bias in our analytic approach. Just a quick note on the phenotyping of the outcome cohorts. So that's how we actually defined our outcome. Thanks particularly, I should say, to Evan Minty, who led the development of the outcome cohorts. As you saw before, prior studies were inconsistent on the definition of the outcome. And what we found when we were defining our cohorts was that the ICD codes were actually used quite interchangeably. And you can see an example here of the complexity of how these codes are interlinked. So interestingly too, adding requirements such as requiring the diagnosis to be in the primary position, that decreased the observed counts by about 75%. So we had to carefully define our inclusion criteria to ensure acceptable specificity of the cases that we were capturing. So now that we have our treatment, our control, and our outcome cohorts, we then designed the analytic approach of our comparative cohort study, and we implemented a comparative cohort study using large scale propensity scores, and we also implemented our negative control outcomes as well. So then all of our study design choices were implemented into a standardized analytic package within the strategist pipeline using the standardized analytic modules in the Hades toolbox. After designing the study and generating the strategist analytic package, we reached out to the data partners who had expressed interest in the study, who already had data mapped to the OMOP common data model. Since everyone's data was coded to the same format, we then ran the database diagnostics on the data sets to see if they were suitable for the study. For those data sets which passed database diagnostics, we then ran the appropriate packages to execute the study on the local systems in the data partner's secure environment. Once the packages were executed, data partners shared only their aggregated and de-identified results across their firewall, and that allowed for centralized analysis and interpretation of the study results. So we had 16, we've got here, data partners across the Odyssey network, I should say, who participate in the study by providing data, and that's indicated by the pins on the map. So let's move on to the fun and exciting part, the results. So for characterization, let's just have a look at the questions we wanted to answer. The first 2 were, among patients who are new users of fluoroquinolones, how many patients experience aortic aneurysm or dissection within a year of starting treatment? And amongst patients who are new users of fluoroquinolones, what's the time to event distribution between exposure and aortic aneurysm or dissection? And over the next few slides, I'll just focus on how many patients experience these outcomes. So the following graph here shows you the incidence proportion of aortic aneurysm or dissection among patients taking a fluoroquinolone for UTI per 60-day follow-up. So from the graph, you can see that the total incidence proportion was less than 0.15 for the 60-day follow-up period. And for females, the incidence proportion was lower at less than 0.1 and sometimes higher for males at approximately 2.7. And that was similar to what other studies have published. If we look at the incidence across age groups, it's clear that the older you are, the greater the incidence proportion. And again, that's in line with prior studies. What if we look at estimation? Here, we wanted to know, does exposure to fluoroquinolones increase the risk of experiencing aortic aneurysm or dissection within 30, 60, 90, or a year after treatment? And does exposure to fluoroquinolones have a different risk of experiencing these outcomes within the same timeframes, but relative to other antibiotics? And so to answer these questions, you can see I've bolded 60 there. We mainly focused on the risk window of 60 days as the primary outcome, since that was what was most commonly reported in prior studies. And it's also the timescale that the FDA used in their warning as well. So here we go. Here we have the results of the IBM Medicaid dataset for the 60-day risk window. Our estimated hazard ratio is above 1, although the confidence intervals do cross 1, so not significant. However, the confidence intervals do contain the estimate that we saw before in the meta-analysis. What else would you like to know to potentially increase your confidence in the results? What about how big the data set is? Do we have lots of subjects? Do we have lots of outcomes? Are we adequately powered to detect a difference should one exist? The IBM dataset here you can see in the yellow box includes records of 35 million people. We had approximately 90,000 target subjects and comparators for fluoroquinolones versus trimethoprim. And down the bottom there, we had 70,000 for fluoroquinolones versus keflasporins. And for the number of events in both groups, we had on average about 30 or 40. What about power? Have we got enough power to detect a risk should one exist? In this case, we can check this by looking at the minimum detectable relative risk. You can see there on the screen, in this case, even with the large number of subjects, we had sufficient power to detect a relative risk of 1.94 or greater. And for fluoroquinolones versus keflasporins, we were able to detect a relative risk of 1.78 or greater. And our upper limit of the confidence interval is greater than 2. So we can't necessarily rule out an increased risk here. So now thinking about the new evidence we've shown you, how confident are you that fluoroquinolones actually cause aortic aneurysms or dissections? Alrighty. What if I show you the results from another data set? Here we've got the Optimey EHR data set. And again, I'm showing you the risk of aortic aneurysm or dissections within the 60-day risk window. On the forest plot, we've got fluoroquinolone versus trimethoprim, has a ratio of 0.92. And on the bottom, we have keflasporins there, hazard ratio of 0.89. So in both cases, no significant increased risk, and the estimates are really close to 1. If we look at the underlying figures to reach this estimate, the numbers now get quite a lot bigger. This data set includes records of 110 million people. We had approximately 478,000 target subjects and comparators for fluoroquinolones versus trimethoprim, and 338,000 for fluoroquinolones versus the keflasporins. And for the number of events in both, we had an average of 200 in each. But again, have we got enough power to detect an increased risk in this case? Well, if the true increased risk was greater than 1.35, we would have been able to detect it. And for fluoroquinolones versus keflasporins, we could have detected a relative risk of down here 1.3 or greater. So if there really was a doubling of risk as identified in the observational studies, in the original ones, I should say, we would have had power to detect it. So now thinking about the evidence we've shown you this time, how confident are you that fluoroquinolones actually cause aortic aneurysms or dissections? Maybe your confidence is changing. A few more seconds to do that. So you've seen the results from 2 large data sets, but you're probably thinking, come on, Jack, what about all the other data sets? I know you had lots of data partners that contributed to the study. So here's the meta-analysis that you've been waiting for. As you can see, overall, there's no significant increased risk of aortic aneurysm or dissection following prescription of fluoroquinolones for UTIs, when compared to those that are taking trimethoprim or keflasporins. And our estimates of effect are really close to 1. So thinking about the evidence we showed you, how confident are you that fluoroquinolones actually cause aortic aneurysm or dissection? You'll be QR coded to death by the end of this. We'll get to the diagnostics soon. Alrighty. So before you get too excited, Mark, remember, big data doesn't protect us against bias. We just guarantee we're more precise with our potentially biased estimate. So who's concerned about bias? We know that given we're conducting an observational study, there are going to be inherent problems with the confounding. So maybe you're thinking, are our treatment and comparator groups really similar? Are we making a fair comparison? In this case, we address confounding using propensity score adjustment. What about systematic error? In this case, we address systematic error with empirical calibration using those negative control questions that we talked about before. So first, if we look at the baseline population characteristics for the Optimey EHR dataset, we noticed that more females were taking trimethoprim compared to fluoroquinolones. And we also noticed that patients taking keflasporins were generally older compared to those taking the fluoroquinolones. Patients taking keflasporins were also more likely to have chronic health conditions like chronic obstructive lung disease, dementia, or diabetes compared to those taking the fluoroquinolones. However, again, after propensity score matching, target and comparative cohorts were more evenly balanced, and the standardized mean difference between the treatment groups was less than 0.1 for each of these covariates. When we looked at the health conditions, those taking fluoroquinolones were more likely to have cardiovascular disease compared to trimethoprim, but those taking keflasporins were more likely to have cardiovascular disease compared to those taking fluoroquinolones. And again, our propensity score matching balanced the cohorts on these factors. When we looked at the medications, patients taking keflasporins were taking more medicines for cardiovascular conditions, diabetes, or psychiatric conditions, and when compared to those taking fluoroquinolones. But again, propensity score matching addressed these differences. So we can also check the balance across all of the covariates before and after propensity score matching by plotting the standardized mean differences of each of the covariates before and after propensity score matching. This helps determine whether the baseline characteristics are sufficiently similar between the target and comparator cohorts after propensity score matching. And so here we're aiming for all of the standardized mean differences to be less than 1, 0.1 I should say, for all covariates after propensity score matching, as you can see here on the y-axis. And in this case, we achieve it in both cases. So the standardized mean differences are all below that orange line. So having achieved covariate balance between our matched cohorts, we now want to know whether our result is generalizable to that original population in the dataset. To do this, we can check empirical equipoise by observing the preference score distribution. So the preference score distribution is a transformation of the propensity score. And here we're aiming for most of the overlap between our treatment and comparative cohorts to be between 0.3 and 0.7. And so a good amount of overlap means that our results will be generalizable. Good equipoise means that even a large propensity score model could not discriminate between the two treatments. And you can see here that we achieve good equipoise in both cases. Now, you might be looking at the graph on the right here wondering, well, the equipoise isn't quite so good here. And you might be wondering what the reason for that is. For fluoroquinolones versus keflasporins, there may have been some reasons why some patients get keflasporins instead of fluoroquinolones. And one of the thoughts around that is, perhaps maybe the patient is pregnant, so we might prefer one of the drugs, maybe a keflasporin in that case. And so you might be wondering, whether keflasporins are actually a good comparator, which is a good question, but we still achieve good equipoise in this case. We can also look at attrition to check generalizability as well. So here for the Optimey EHR dataset, we started at more than 1 million people exposed to the fluoroquinolones who had a UTI. And we had more than 600,000 people in our comparative cohorts for both trimethoprim and keflasporins. As we can see in the graphs, the biggest source of attrition was propensity score matching. And there's lower equipoise in the fluoroquinolone versus comparison because there were less matches. When we looked at the preference score distribution across the databases for fluoroquinolone versus trimethoprim, we noticed fairly similar patterns across the databases, although there were a few that had different patterns, and you can see that they're mainly from the Asia-Pacific region, so Taiwan, Korea, and Japan. And you'll note that for trimethoprim, the three databases on the right here didn't pass the diagnostics as the application of the propensity score matching didn't balance the covariates between the treatment groups. So if you do want to learn more about the diagnostic checks that we've sort of described already, you can check out Martine and Nicole's diagnostics tutorial tomorrow. We also noticed a similar pattern across most databases for the fluoroquinolone versus keflasporin comparison too, but now we see that for the keflasporins, there was lower equipoise found for the US databases and better equipoise for the Asia-Pacific databases. However, regardless of the differences in the equipoise, we still get similar estimates in the meta-analyses. So I said that we measured and addressed confounding, but could there be systematic error in our analysis? So this is the error that could happen due to design and analysis choices. We can estimate systematic error by using negative control estimates and compare our results against a known truth for outcomes that are unlikely to be associated with fluoroquinolone use. And so we can measure systematic error by using the EASE score, which is the expected absolute systematic error. So in this study, I said before, we included 50 negative controls when checking for systematic error. In the graphs here, the estimates below the line are statistically significant from the true effect size, whereas the ones above are not. We expect that our 50 negative controls should return an estimate and confidence interval that contains one. And because we're using 95% confidence intervals, we would expect that the confidence intervals would contain one 95% of the time. In both cases here, you can see that 92% of our negative controls estimates have a hazard ratio with confidence intervals that include one, which is very close to what we'd expect. Therefore, we have sufficiently low systematic error, and therefore our E-score is close to 0. Because our E-score, systematic error, is so low and the E-score is close to 0, you can see that the calibrated and uncalibrated estimates are actually quite similar in the Optimum EHR database. So there's very little systematic error or unmeasured confounding that we're not accounting for in our results. So I'll show you the meta-analysis again as a reminder before we move on to seeing again how confident you are in the results. So I should also point out only 7 of the 13 or 16 databases that run our analytic package are included in the meta-analysis. And that is because we only include databases results for which all diagnostics were passed. So we've measured and addressed confounding, and you've seen that there's very little systematic error, and you know that only those databases that pass all diagnostics are included in that meta-analysis. For the last time, how confident are you that fluoroquinolones cause aortic aneurysm or dissection? Alrighty. So I guess just some summary comments. We've taken a journey through a series of objective diagnostics, which helped us to objectively interpret the reliability and the validity of the evidence we produced. And at each point in our journey, we were willing to stop if we failed diagnostics. And our final meta-analysis, as I mentioned, only includes results of those databases that passed our diagnostic checks along the way. Lastly, as we sort of talked about before, one of the most important aspects of trust is transparency. And so to address this, we publish all the results of the study in an open source format via a Shiny app. And the results of this study can be found at data.odyssey.org/fluoroquinolone aortic aneurysm. Don't forget that last slash as well. You can search this Shiny app pretty easily to see the results of all the analysis that we performed. One last QR code. So remembering back to the start of the presentation, and we looked at the results of those original studies that were published in the last 10 years or prior to that, and remember about how confident you were in the evidence. Now that we've shown you our approach to generating large-scale evidence, out of 10, how confident are you that the evidence presented in this study is reliable and can be trusted?
So I'm just going to quickly go through the results of what you all said. Remember, Jack's first question was based on the literature and the various studies that were done. How confident were you that that evidence was reliable and can be trusted? So what you can see here is that first question about the prior literature. You guys in the room had a range of perspectives about how confident you were that that evidence was reliable. Some of you said that you're not at all confident. Some of you said they were completely confident. So you got the full spectrum, but we can see across that range there. I'll drag my mouse over here. The next question Jack asked you was, based on the evidence that he showed you from the literature, how confident are you that fluoroquinolones cause aortic aneurysm? In this case, nobody was completely confident that they did, and nobody was completely confident that they didn't, but you all had a nice normal distribution centered around about 50%, so that it may or may not have. What Jack then did was went through a series of additional pieces of evidence. So remember this distribution as your benchmark. The first thing that Jack showed you was one more database, a single study from a single database. And this is how you all kind of moved your perspectives. Doesn't seem like you moved all that much. Still tremendous uncertainty, and still some of you erring on the side of being not confident or erring on the side of being confident. Now, the reason I think this is a useful exercise to think about is 95% of the publications that you read is a single person studying a single database, and then you are supposed to be informed by that information, and we can see that the uncertainty here. Now, Jack then added one more database, the Optimey EHR, and here now you had two databases. You had one that was slightly underpowered, one that was more powered and was not suggestive of increased risk. You now can see the distribution is shifting a little bit here. Now, more of you had lower scores, believing that there was maybe not so much belief that effect, but you still had a range, and you still had several of you that were above 70%. The next one that Jack showed was the meta-analysis, showing you the results of all of the different databases. Now we see a pretty substantial shift. Now, instead of having that one-off study of one database, you're now actually seeing a network study across databases around the world, collectively showing you consistent evidence of no effect. And it seems like that swayed many of you. But now the majority of you believe in either there's no cause or only a 10% chance of an effect. The last piece that Jack showed you was adding on to that study diagnostics to demonstrate the integrity of this evidence. And you can see that here, interestingly, the distribution really didn't shift that much. It looked like a lot of you were trusting of the evidence without seeing all of the diagnostics, though the distribution seems relatively consistent, that at least it reaffirmed the belief that you had there. The last question we asked was, how did you think about the confidence and belief of this Odyssey study? And I was relieved to see that many of you do indeed believe that the Odyssey evidence is reliable and can be trusted. Maybe a biased audience here, just possibly. Though during lunch, I really want to talk to the 9% of you who thought that this study was not reliable. So please find me at lunch. So there's your snapshot. Okay, we may have some data error. I hope that there's some data error. So there's your summary. Thanks.
So let's open up to the floor. So we've got some roving mics around. Yep. So go ahead, Graham, I think.
Yeah, thanks. I'm a clinician. I've worked in intensive care for 40 years, and I've seen a lot of patients with aortic aneurysm. So I guess the things that concern me about the clinical plausibility of all of these observational studies is, how do they fit into the understanding of clinicians around the real-world environment from which the data is taken? And the first thing that occurs to me is that this is a very serious disease, and that a lot of patients die before they get to hospital. So the underlying premise here is that the proportion of patients changing after exposure with a urinary tract infection or exposure to these drugs hasn't changed, and therefore we can make some assumptions about the observable data rather than the total data, because we're missing potentially up to 30-40% of the patients that might be killed by this stuff. So then the next question that sort of strikes me is, well, urinary tract infections come in very different range of severities. So, you know, people get a bit of cystitis versus those who end up in ICU in septic shock. And there's a variety of different causes that could be lumped under urinary tract infection. So is the premise of this disease an inflammatory process is in response to severe urinary tract infection, or is it related to the drugs that are used to treat the UTI? So, you know, I think when I look at a paper like this, I can see that there's probably not going to be any difference between the two different drug classes that are used, but I still don't get a feel for whether the underlying rate of the disease itself that we're measuring is any different from baseline. So I'd really like to see a comparison of the incidence of urinary tract infection, the incidence of aortic aneurysm or aortic dissection, because there are some different etiologies for both of those and how they're kind of impacted. So I guess the problem with all the observational studies is that we report on what we can measure and what the data we have. And I think the systematic biases around what's missing in the data set is really important for the consideration.
Yeah, so that's really great questions. And again, the aortic dissection or aortic aneurysm is really serious conditions. And my first mortality case for the presentation was aortic dissection case. We did not identify that the patient had an aortic dissection. We thought that he had a myocardial infarction rather than aortic dissection, and we did angiography, and then we lost him. So, yeah, it's truly a serious condition, and it is truly important whether this drug is related with the aortic aneurysm or dissection. And we define the underlying condition, infectious condition, as a UTI because it is more prevalent and is one of the indication for fluoroquinolone. And actually, we planned to conduct another study with the indication of pneumonia, which is a little bit severe infectious condition rather than compared with the UTI. That's one of our plans. And about how we balance the severity of the UTI occurs between the two drugs or between the populations. We actually did not, I'm not sure that we can guarantee we did balance the severity of UTI, but still we balance more than 10,000 covariates at the based on the day of initiating the drugs. And I think that is enough to balance the severity of UTI between the two, target and comparator. And we chose two different comparator, cephalosporin and Bactrim, it's trimethoprim. And in the clinical perspective, that trimethoprim is somewhat narrow, the antibiotics with narrow spectrum and somewhat weaker. And then cephalosporin is has much more broad spectrum of antibiotics, which is a little bit stronger. So we picked two different competitors to produce more comprehensive view, and we tried to provide comprehensive evidence about this issue, but there is limitations of our approach. Of course, since it is not, that we are using the data as a secondary use, not the primarily. These data are not produced for the primarily for this study. So there, of course, there is a limitation. We acknowledge that, but we tried our best to address this question. That's my answer.
Thanks, John. We've got a question. Yeah.
Hello, my name's Angus. I'm a renal physician, which means I'm used to operating with little evidence in a lot of the things that I do, and a reasonably experienced clinical trialist. And my question is going to be about the translation of evidence like this into practice. I'm going to ask Jack and the consumer representative, but just a couple of comments to set that up. Aneurysms are generally slowly developing progressive conditions that occur over years. and dissections are usually sudden and rapidly fatal if not treated. They're very different conditions. And most prescribers wouldn't link them, either of them, with quinolone antibiotics or any antibiotic for that matter, actually, unless it was in the context of sepsis and heart valve infections, that sort of thing. And so when I think about these two problems, I should also comment that in Australia, the fluoroquinolones are highly, highly restricted. They're slightly easier to get than a gun, but they're still very highly restricted, which means our usage is very, very low. And you probably see that, I think, in the population differences in the prescribing of different antibiotics. We would mostly use penicillins, which were not up there at all. When you look at that data, I think if you are a prescriber who has prescribed a drug that's led to a rare complication, that significantly changes your practice. If you are a patient who experiences or is a victim of a rare complication, you care very much about that, but you may not have cared about it at the time you were prescribed it when you were sick, and you may not have had that same capacity to decide. So thinking about all those factors that go into the decision to write a prescription and a patient's decision to take it, Jack, what do you think, based on your evidence, a prescriber should do differently? And to our consumer representative, how might you think about what would you be expecting of the prescriber if you're trying to translate this or any other similar evidence into practice?
Jack can go first.
I think that's really, thanks for the question. I'm a practicing pharmacist in a community setting. And actually on the weekend, I was just talking to Nicole about this. I had a patient present to the pharmacy, barely being able to walk. And the first thing the ambulance asked me was, has the patient had a history of an aortic aneurysm? And it sort of shocked me because we'd been doing this research for like 2 months. And I'm like, man, someone's just walking into my pharmacy and they're potentially having one, right? Really sharp, like lower back pain, sort of radiating and everything. And it made me think about, what information I'm giving to someone when I'm handing out their medications, and, is that appropriate depending on what I know about the medication? In terms of how prescribers should communicate differently, I think that's a really tough one, I don't know, for me to answer. But I think it's, more about having that conversation with the patient, I guess, about, this has considered to be a risk in the past, but perhaps it's not so much of a risk, but, it's something that we potentially need to warn you about. But the risk may not be there. Maybe there's room in Australia for more monitoring of, things like this as well. You often hear about people having, brain aneurysms and that, which are, only happen every now and then. But again, if people have that imaging done more routinely, then perhaps these things could be picked up sooner.
Yeah, I'm not going to thank you for that question. That's really hard. Look, I think, as a patient and as I've got older, my needs around medication are different. Now for me it's about quality of life and, about how it's going to interact with other medicines I might take. Thankfully, I've not, been in this situation, although I have to say it's interesting for me that my father died from this aortic, aneurysm 40 years ago, and he didn't, whoever you are down the back, he didn't get to the hospital, but I think where it comes in is having a trust in the system, and I think, having a trust that we've got a TGA that interacts with clinicians, and I'm sad to say that the HTA process in Australia doesn't include clinicians and patients as well as what it should, but watch this space because that might be going to change. But I think having the trust in you as a clinician to say to me, there is a risk for this medication, but in all things considered, I think this is better, and knowing that you can go to the TGA and get that real world evidence is is most times enough. Because, and it's not about blind trust, it's about a trust in health professionals, and they are trusted, of course they are, and having a trust in research, because like Korea, Australia has a trust in researchers. So I think all of those things, what doesn't work well is the silos. And we have a very siloed health system in this country. And I think the more we talk about it, the more you have people like me and people like you asking me difficult questions. But I think the more that we have those conversations, we're going to bring a better outcome for all of us. I think you're right. COVID made a real difference to how the community, and I can only talk about here and in some parts of Europe, it made a difference to how the community viewed research and the importance of it, so that we got a vaccine quickly, et cetera, et cetera. So I just think we've got to keep talking to people. And when I was thinking about this yesterday and last night particularly, someone said to me many years ago, my job in the university started because of linked data was coming to Perth, and the health consumer community was worried that Big Brother was coming. This is the mid-90s, mind you. And, someone said when I first started this job, okay, it's all very fine. Data will tell you all the things that you need to know. And you've just found that out with all these millions of bits of data, but the person will tell you why it's happening. And so I think you need to all remember that, is you've got to talk to people about it and, give people the option to say, and most times they'll listen to you, I'm sure. Thanks.
Can I just make one further appeal on that in terms of the communicating the answers?
Yeah.
The spectrum of opinions you saw about the evidence would reflect if you surveyed a room of general practitioners about their belief in the evidence, and that we need to communicate it to the medical audience, the prescriber audience, or the target audience needs to change their behaviour. And things like simple visual abstracts are good. Most of us can recognise a forest plot. That makes sense. The rest of it, a lot of it went over my head. And so I think we need to think carefully about communicating to the general health community as well.
You should be living in my shoes looking at those presentations.
We're nearly out of time, but if we've got a really quick question.
Hi, Jacques Rabnheimer from the University of Sydney. Thanks, Jack, and thanks to the panel. This was really interesting. Just getting to that thing about communicating our findings to the public, maybe just a comment rather than a question so that we can finish quickly, but don't we also face a kind of a media bias? We all know there's publication bias, but I'm just thinking of a recent experience I had dealing with the media, that if we find something that has a definite harmful impact, or you could flip it over, something that has definite benefit, aren't the media much more likely to take that up, and the regulators, in fact? And when something like this, where we see there's no real harm, it's kind of like nobody wants to pay attention to that.
Could I just say, though, patient organisations around the world, nationally and internationally, are very interested in information like you've just put up. So I think you can engage, and there's a lot of them, so I think you can engage better with them.
So perhaps we're out of time, so maybe we can, as a panel, you could each perhaps give a reflection of the session and perhaps what it means to you in your practice and what we can do in the future. So Grant, do you want to start? Do you want to describe
That's
it?
right, I can speak loudly. To me, it just demonstrates the importance of connection. All the various pieces of the puzzle. If we can connect them, we can solve big problems together. But it's complicated, but we're going to start somewhere.
Yeah, I've less focused on the engagement of patients or more public community, and I think I see the importance of this, and then please give us more money and time so we can develop more, visualization tool or, much better tools to, communicate. Thanks.
Yeah, I don't really have anything more to say, so over to you.
Okay. Yeah, I think from this conversation, my reflection is we really need a communication section just to help us to have these transdisciplinary discussions, and so that we can explore more about so-called unknown unknowns. So we have tried our best to explore the known unknowns, including those, residual bias and stuff. But we need to bring people from different disciplines together, and also have self-reflection about whether we have communicated our evidence at our best ability.
Agreed. So that's us at the end of this session. But I just wanted to quickly say, when Azia showed her presentation earlier and Patrick showed his presentation earlier, and we saw the work groups up there, there was a lack of consumer engagement in those work groups and a lack of just communication in general. So as a community, I wonder whether we should actually propose a new work group that actually addresses some of the issues we've talked about today. And if anybody is interested in joining in a work group like that, we can just make one. We'll make one and add it to the community. So that's been an absolutely wonderful discussion. Thank you so much to the panelists, to Jack, to Chan and the Korean team, and everybody who collaborated together on the SOS challenge. It was just one of the best kind of things I've done so far in my career, I reckon. It's been a wonderful journey. So thank you very much. Thanks again to the panelists.